Welcome, Dr. Pal, and we are very keen to hear from you, sir. Over to you.
Namaste. Thank you. First, let me thank Swasti for giving me the opportunity and the Ataxia Awareness Society also, and of course Apurva is there, a long-term colleague of mine. Okay, so I'll just share the slide first. I will not be able to speak, grammatically Hindi, correct Hindi, and already Gayatri has dealt with some of the clinical aspects, but I'll be mainly dealing with the clinical features and how to go about the management aspects. Okay, so I just first share the screen. Let me see how to. Okay, so okay,
Up arrow within the box.
yeah. Can you see here the screen?
Yes, sir, we can.
And you can hear my voice.
Yes, very clear.
Okay. So in the next 20 minutes or so, I will, this was a topic which Swasti told me to talk on: clinical features, challenges, and management of SCA 1, 2, 3, and 12. These are the things which I will discuss: clinical features, differential diagnosis, key challenges, and current management strategies. Um, So already you have heard in the previous talk that the SCA or Spinocerebellar Ataxias are genetically and clinically very different type of group of disorders, and they're autosomal dominant, which already Gayatri has told that it passes down from one generation to other generation, either from the mother or from the father, and it is a neurodegenerative. That means there is a death of the cells in the brain, mainly in the cerebellum or its connections from the early childhood. And though these sentences you did not keep attention because these are all technical terms, and what is known as it is a monogenic disorder with a high penetrance. That means there is a high chance that it will pass down to the next generation. And as already been highlighted, there are more than 50, almost 48 to 50 SCAs which has been identified. Now, this term SCA is now being used in a different context also, like Spinocerebellar ataxias, which are autosomal recessive disorders, which begins in different, very early childhood, and those are different disorders. So I am going to speak mainly on the autosomal dominant, which is a classical SCA or Spinocerebellar ataxias. Now, just to give a highlight of the geographical distribution, you can see here that throughout the world, SCAs are seen. Okay, and in general, it is about 5 to 6 cases per 100,000 population, and commonest worldwide is SCA3, or is also known as Makato-Joseph disease, and then followed by probably SCA6, SCA2, etc. But in India, we find that SCA 2, 3, 1, and 12, they are the most important SCAs, depending on the type of region or the ethnicity we are looking into. That will come to later on. Now, already this has been highlighted earlier that, see, these are what is known as an anticipation that it the severity of the disease increases from generation to next generation. And also, if the father was affected, of a patient whose father was affected at the age of say 30 years, maybe the next generation will get a higher repeat length of the CAG repeat which was told, and that child will get earlier disease. Even I have seen, so these are some of the representative families. You can see SCA1, SCA2, SCA3. So from one generation goes to next generation, you cannot read the age of onset, what we say, but gradually different generations come down even to, I have seen a child with SCA2 who is only just 5 years old. Okay, so the repeat lengths go on expanding one generation after next generation, etc. And then the clinical features, which I'll come to later on, increases significantly in a different way. Already, so what are the core features of these four diseases? SCA 1, 2, 3, and 12. 12 is little off the way because the age of onset of the 12 is much later. but mainly for SCA 1 to 3. Main problem is the balance problem. So balance problem can, come back either in the, start with the hand and the legs. So if you try to catch something, your hand shakes, or you have a balance problem going in a single line, straight line. These are the very early things which can start happening. Then you can have a difficulty in speaking, like a patient or a person who has a cerebellar problem tend to speak in a little different way, what is known as scanning speech or explosive speech, one sentence by sentence, word by word, it is as if like a scanned. So these are the problems which can occur. This is known as dysarthria. And some patients, especially SCA 12, can have what is known as a tremor or shaking of the hand like this. I'll show you one or two videos. But apart from this, there is also what is known as a eye movement abnormalities. All cerebellar patients can have nystagmus. Nystagmus means if eye goes to one side, there will be a jerky movement, especially on one lateral gaze. They can have some visual problems also, like seeing in the darkness, there's a problem, etc. But some additional findings can be there, like pyramidal signs, like other tracts in the brain gets involved, like corticospinal tract. Okay, they can have stiffness of the legs out of proportion to another disease. Then other extrapyramidal signs, like already earlier told you that SCA2 can have like a Parkinsonian features, slowness, stiffness, apart from the balance problem. Even in the beginning, the balance problem may not be there. It is only, it looks like as if like a Parkinson's disease. Then another very important thing, especially in SCA2 followed by SCA1 and SCA3, is ophthalmoplegia, or means eye movement abnormalities. Like I'll come back later on. You tell the person to look to the right, look to the left. He or she will not be able to look suddenly as fast as we do it. We move our eyes at a velocity of some 600 degrees per second, but here it will be very slow. Gradually the child or the patient will try to move the head rather than move the eyes. So there is this slow saccades, it's called slowness of the eye movements. And sometimes later on the eyes get so stiff that only the head has to be moved, eyes cannot be moved. So this is known as a head thrust. Okay. And then sometimes in the later stages, but not much in these core disorders, you can have memory problem, etc. So usually in our country, whatever in my vast experience over 30 years, that we have seen most of the patients come around within the age of 20 to 30. Okay, to start with. But nowadays we are seeing, because this generation, the next generation now, the earlier age of onset is happening, even coming at 15 years, 13 years, 6 years, etc. But this is mainly for the SCA1, SCA2 also the similar, SCA3 similar, but SCA12 usually starts around the age of 30, 50 or 40, etc. because it is a little different pattern of problem. Now, these I have already told, I'm not going into the details. So this is SCA1. All types of SCA 1, 2, 3, 12 become almost similar. But this, what I'm telling, is in the initial stages. Okay. So as already told that, in SCA3, what is known as the Macaronis disease, there are 3 different types based on, the repeat length, which is in what range it is expanded. So it can be fast progression, slow progression, intermediate progression, and some of the patients develop what is known as a peripheral neuropathy. The nerves in the legs get affected first, or they can develop what is known as a distinct posture of certain parts of the body. So if you see those features, we can, even without genetic testing, we can diagnose them as a SCA3. SCA12 is little different. SCA12 is commonly reported in one particular community in India, which is Agrawal community, and there are further, linkage, blood linkages like Guptas, etc. So they usually come with a hand shaking and balance problem, and these can go on for a long time. Initially, actually, we were thinking that these patients are having what is known as an essential tremor or only a tremor disorder. But later on, we found that after this gene was identified, that they are suffering from a CAG repeat disorder. This is also, I'm not going to do the details, but just now, whatever I have told, you can see here that depending on the repeat lengths, different type of signs and symptoms can occur apart from the cerebellar signs like balance problems and eye problems. Other problems can occur depending on the different type of genetic dose or abnormal genetic problem. So you can see here small repeat, medium repeat, large repeat, very large repeat, all have different types of, SCA2. I'll tell you, I saw a child whose father was having just a normal, just a cerebellar ataxia, incoordination, balance problem. But the daughter who came, who was 6 years, started at the age of 6 years with a very high repeat length. And the child was developing jerks, that is called myoclonus, and a twisting of the body and eye problem. So these can occur because in subsequent generations, the pattern of disease changes. Now, please do not record these videos because these are from certain patients who has given consent for showing these videos long time back there. So this is what is known as a ataxia. You can see we do not, a normal person can walk with a narrow base, but here you can see with a big, broad, the legs has to be separated out to balance them. So this is known as a gait ataxia. Okay. Now, this is a patient, a patient which it's SCA1. So here you can see here eye movement abnormalities. I'm telling to look right or the left is little slow, and eye movements apart from slow, which I'll show you in later on in another video, they have reduced facial expression like a Parkinsonian features. And if I can move it a little forward, you will see soon that this patient, just let it progress 1 second more. So what we know, these alternating movements, they have a difficulty, patients with ataxia. And again, you can see here, he's walking in the broad base, and the reflexes, what I told you was the pyramidal signs, becomes brisk in these patients in SCA1. See, very brisk, these things compared to SCA2, who has a peripheral neuropathy. So this is a patient of SCA2, which I was telling you that I'm telling the patient to move up or down the eyes or move slowly. All are abnormal. You will see now I'm telling to move right, left side or right side. It is very slow. Okay, this is the slowness I tested. Now I'll tell him to look very fast. You will see that here. So I'm telling him not to move the head, and I'm telling to move on the right side or look towards the left side or look towards the right side. He's not able to look to the eyes. He's jerking his head. That is known as a head thrust. Okay, and in these patients, the cerebellum, which is MRI shows, there will be atrophy or reduction in the volume of the. Okay, so this is another one patient of SCA3, where just to show you that how dystonia looks like. So I'll just go cut this short. So you can see here there is a bending of the hand, a body, apart from the dystonia, apart from the ataxia. And when he walks, you see his feet and body are all bent. I've cut off the upper part because I do not want to show. But this is also a SCA3, but this is a different repeat length compared to the only ataxia or balance problem. This patient is a twisting of the body. And this gentleman, SCA12, again, I've cut off the upper part. But you can see here some shaking of the hands. But you will soon see that there is more hand movements. You can see here this type of hand movements. If you see my hands, and is a very, very severe ataxia. And so this is also, he has a mild ataxia, but mainly is the tremor. So this is known as SCA12. Okay. Now, I'm not going to go into the details of differential diagnosis, because if you come to a neurologist, most often you will be able to diagnose, the neurologist will be able to diagnose SCA1, 2, 3, and 12 if there is a family history. Now, the problem occurs when there is no family history. No one in the family has suffered similar disease. So it can always start with somebody who did not, no family members had got that disease, because it is de novo mutation can occur. So we have to be careful about these diseases, and also some of the autosomal diseases, ataxias, Wilson's disease, some of the acquired ones like vitamin E deficiency, B12 deficiency, some problems in the spinal cord or Arnold or CV junction anomaly, then some of the episodic ataxias or infection or immune-mediated ataxias. Some patients can have a malignancy in the later ages and can have what is known as a paraneoplastic syndrome, which can mimic like ataxia. Or in the later stages, in the later age, you can have what is known as a multiple system atrophy type C, where there will be it is not a genetic condition, usually not a genetic condition, but the progression is very fast and they have low blood pressure, etc., etc. That is known as multiple system atrophy. But I'm not going to, obviously, there's no time for that. So now let us come to, is there any cure? There is no cure for SCA, and treatment aims to reduce the symptoms of all the symptoms which I mentioned to improve the functioning. So usually use mobility aids, fall prevention measures, eating aids, physical therapy to strengthen the muscles and improve the gait and balance, medications to reduce the shakiness, stiffness, and muscle spasm. And see, you should all know that suppose we are born with, say, 100 good nerve cells in the cerebellum. Now, a person with SCA, maybe the 50% of those cells are dead. Okay, but remaining 50%, we can train them by doing balance exercises, eating a healthy diet, etc., to improve the functioning of those remaining cells. So many of these drugs has been tried with trials like riluzole, valproic acid, varnicillin, lithium, but there is no definite results. So basically, the treatment is sometimes we can give levodopa in patients who have Parkinsonism in SCA2. Otherwise, we have to give baclofen for stiffness or botulinum toxin for if the dystonia. Many of the patients can develop urinary problem, either too fast passing the urine, urgency of micturition, what is called. Then you can give some tablets to reduce that problem. Some patients can develop pain in the legs, or some patients can develop depression and etc. For that, we can do treatment. So these are the drugs, but I'm not going to discuss all these details because I will rather take some questions from you. So they are the drugs which can be given to reduce the. This is called symptomatic treatment. It is not a cure. Okay. So let us come to some of the mobility aids. So this courtesy of some of my colleagues, Anu Agarwal. So this you can see that wheelchair, apart from the wheelchair, which is needed in the later stages, because the hands can function properly, many patients, depending on the severity of the disease, can be managed, using a proper cane or type of, a wheel walker, a different type of walker with a heavy base or with wheels or with brake. These are different. Their physiotherapists will guide you. Then to prevent the falls in your bathroom, the handrails has to be put, or a anti-skidding mat, and so the lighted staircases. So these are things which a physiotherapist or occupational therapist or things can guide you, a bedside commode, etc. Sometimes spill-proof bottles are available, a spoon or things, a bigger handle is available. And this is, whenever I have patients of SCAs, I send to my colleague, Dr. Selva Ganapati, who does all this training. We give balance exercises for about few days, and then the patient is advised to do this type of, in a different type of mats. We do the side walk, or this is called Frankel's mat exercises, narrow feet stance. So they will explain this, what to do, and you can practice in the house. So this is a simulation of a staircase. Balance, this is called biodex balance system, where you can, we have measured in many patients what is the anterior, posterior, and lateral limits of stability, it is called. So based on that, our doctor physiotherapist will advise to do training on that balance system, what is the biodex balance system. Then walker and gait ride, etc., can make the, we can understand how much is the deficit, what is the deficit, and try to help you. The future directions are there for treatment, like, this I'm not going to go into details. Antisense oligonucleotides, RNA-based therapy, stem cell therapy. These are not for any meaningful treatment in the current scenario. These are all in the early stages of, trials, etc. There is not for treatment in the day-to-day practice. Sometimes some people have used transcranial magnetic stimulation, reverberative transcranial magnetic stimulation, as well as direct current stimulation, etc. But nothing has helped. These help for about few days, etc. But we do not know what is the placebo effect or not, and so nothing actually helps as of now. But more studies needed whether we can get some treatment for SCA 1, 2, 3, and 12. Now, I just want to have one more caution to you, that there are many patients who have SCA 12 mimic as a very severe tremor of the hand. Should we do surgical treatment of tremor? Many people have come to us for deep brain stimulation, for other high flux related thalamotomy, for tremor treatment for the ataxia, for the by surgical treatment. in general, we do not advise because the moment the tremor is gone, the ataxia or the balance problem increases much more, and that may be much worse. So, as of now, surgical treatment, even for SCA12, who has a very severe tremor, is not advised. So, I thank you for your attention, and I'll be happy to take any questions. Thank you.
Thank you so much, sir. That was very insightful and काफ़ी काफ़ी सारी knowledge मिली. I would like to tell you, sir, your English was not the barrier here. We were very easily able to understand what you were presenting, and thank you so much for this wonderful presentation. साथ ही मैं हमारे सभी साथियों का धन्यवाद करना चाहूँगा, डॉक्टर पाल का, डॉक्टर पुराणिक का, स्वस्ति जी का, एटैक्सिया अवेयरनेस सोसाइटी का, कि न केवल एटैक्सिया की पर ऐसे प्रोग्राम्स से जेनेटिक काउंसलिंग की भी काफ़ी अवेयरनेस होती है. और सर हृदय ये कहना चाहता हूँ कि इस तरीके के प्रोग्राम्स हम आगे भी करते रहें, और इससे हम जेनेटिक काउंसलिंग के थ्रू जिस तरीके से हेल्प कर सकते हैं वो प्रयास हम आगे कंटिन्यू रखेंगे. अब चलते हैं क्वेश्चन एंड आंसर्स की तरफ. हमारे पास दो लोग हैं जिन्होंने रेज किए थे. एक है मिस्टर विनोद कुमार काथरामल्ला. मैं आपसे रिक्वेस्ट करूंगा सर, प्लीज खुद को आप अनम्यूट कर सकते हैं. खुद को अनम्यूट करके आप अपना क्वेश्चन पूछ सकते हैं. विनोद जी, प्लीज फील फ्री टू आस्क अ क्वेश्चन. You can unmute yourself, Vinod ji. You can click on the mic button on your screen. आप unmute हो जाएंगे उससे.
Can you able to hear me?
Yeah.
Go ahead, please.
Sir, I am a C3 patient from Hyderabad. I am having a lot of body weight things. Can you suggest me tablets?
आपको क्या बोल रहे हैं आप? बैलेंस का प्रॉब्लम बोल रहे हैं?
Yes, I could not able to walk.
या सो अभी जो हम आपको हम इंग्लिश में बोलेंगे, हिंदी में बोलना है?
ये हिंदी लैंग्वेज.
नहीं तो वो जो आपको कोई डिजीज बोला है, आपको क्या डिजीज है?
ये
एसीए. कितना साल हो गया?
10 years.
तो बैलेंस का तो कोई स्पेसिफिक ट्रीटमेंट तो नहीं, मैंने टैबलेट का ट्रीटमेंट नहीं है, बट आपको जैसे हम बोल रहा था कि आपको कोशिश करना है वो वॉकर लेके चलने के लिए. नहीं तो वॉकर अगर नहीं होगा तो व्हीलचेयर से चलने होगा, बट यही है तरीका. एटलीस्ट आपको डेफिनेटली कॉशन में रहना चाहिए, जे गिरना नहीं चाहिए. दैट इज द मोस्ट इम्पोर्टेंट थिंग. ओके, सो जितना स्टेबिलिटी हो सकता है किसी का सहारा लेके चलने होगा, नहीं तो वॉकर लेके चलने होगा. वॉकर लेके आप चल सकते हैं?
ये नो सर.
कोशिश किया है आप वॉकर लेके? बिकॉज अगर आपका
Yes.
हाथ का स्ट्रांग है, सो हाथ का स्टेबिलिटी अगर है तो उधर में ब्रेक भी होगा. सो वॉकर पुश करके भी चल सकते हैं. कुछ कुछ वॉकर में सामने 2 व्हील होता है, कुछ कुछ वॉकर में 4 व्हील होते हैं. 4 व्हील वी नॉट एडवाइस, बट सामने 2 व्हील थोड़ा सा वेटेज होता है, उसमें बैलेंस थोड़ा सा बेटर होता है. तो अगर आपको कोई फिजियोथेरेपिस्ट को आप कंसल्ट कर सकते हैं तो वो डेफिनेटली एडवाइस करेंगे जो बैलेंस कैसे इम्प्रूव करना है. और एक चीज है, जो वेट आपको अगर ज्यादा हो गया तो वेट को कुछ तरह से आपको कम करना है, बिकॉज आपको होल बॉडी का वेट वो पैर के ऊपर गिरता है, और अगर पैर के ऊपर वो वेट होता है तो चलने डेफिनेटली दिक्कत होगा. तो जितना आप वेट कम कर सकते हैं, अगर ज्यादा वेट है तो वो बेटर है. वेट हाउ टू
हाँ.
रिड्यूस? वो तो देखिए आप मतलब ये जो एससीए है उसमें कुछ ये नहीं है जो आपको क्या खाना नहीं खाना, इज जस्ट लाइक ए नॉर्मल पर्सन के लिए आप खा सकते हैं और कुछ नहीं खा सकते हैं। स्पेशली जस्ट जस्ट विटामिन थोड़ा सा ज्यादा खाना है, लाइक विटामिन ई एटसेट्रा। बट डाइटिशियन को पूछ सकते हैं कैसे वेट कम करना है, ये तो डेफिनेटली कोई बोल नहीं सकता है। बट अगर आपको वेट ज्यादा हो रहा है तो दूसरा जो कारण हो सकता है, लाइक थायराइड प्रॉब्लम, कभी कभी शुगर का प्रॉब्लम, वो कभी कभी डिफरेंट मेल न्यूट्रिशन, ऑल दिस थिंग्स आपको देखना है। जो दूसरा कोई कारण है क्या वेट आपको ज्यादा अगर हो रहा है तो यूजुअली वेट ज्यादा हो जाता है बिकॉज एक विशियस साइकिल है। आप चल नहीं सकते, उसके लिए एक्सरसाइज नहीं होता है, एक्सरसाइज नहीं होता है उसके लिए वेट बढ़ जाता है। तो ये एक बैलेंस करना है, तो आपको जो फिजिशियन है उसके साथ आपको बात करके वो करना है। ठीक है।
सर नेक्स्ट क्वेश्चन पे चलते हैं।
हम्म।
नेक्स्ट क्वेश्चन है मिस्टर अनूप बंसल का। अनूप जी, आप खुद को अनम्यूट कर सकते हैं। मिस्टर अनूप बंसल। मिस्टर अनूप जी ड्रॉप ऑफ। विनायक महाराष्ट्र जी का है अगला क्वेश्चन। विनायक जी, यू कैन अनम्यूट योरसेल्फ नाउ। विनायक जी, आप अपने स्क्रीन पे माइक बटन प्रेस करेंगे, यू कैन अनम्यूट योरसेल्फ। एक और क्वेश्चन है सर, रिटन फॉर्म में आया है।
हम्म।
It out. So Ravi Krishnamurthy is asking, some doctors in Bangalore claim treatment for ataxia. Is it true and worth pursuing?
ट्रीटमेंट फॉर अटैक्सिया इज इट?
True and worth pursuing.
See, वो तो treatment, not only there is, see, if there is no tablets or oral treatment, does not mean there is no treatment. We say about management rather than a treatment. Okay. Ataxia, ataxia is a very broad term. What I'm talking is only SCA, that is Spinocerebellar Ataxia, is a neurodegenerative condition. Okay. There are certain types of ataxia now also in the SCA category which has been identified. See, SCA 1, 2, 3, 12, कोई treatment नहीं है. This is 100%. There is no stem cell. There is no role of stem cell treatment at all in this category. But अगर SCA earlier जो लग रहा था कि SCA नहीं है इसका, ऑल जेडी टेस्टिंग किया है, बट आजकल लग रहा है कि SCA 27B करके एक SCA रिसेंटली डायग्नोज हुआ है, EIGF का जो ग्रोथ फैक्टर से जो वो तो होता है, उसमें ट्रीटमेंट है। आजकल दिखा रहा है जो उसमें 4-अमाइनोपेरिडीन देकर उसका ट्रीटमेंट कर सकते हैं अगर वो टाइप के एससीए है तो। ठीक है। देन कुछ कुछ टाइप के एपिसोडिक अटैक्सिया होता है जिसको यूजुअली नॉट एससीए बट समटाइम्स एससीए 27 आल्सो, मींस जो कभी कभी अटैक्सिया होते हैं, मतलब बैलेंस प्रॉब्लम होता है, कुछ दिन ठीक रहता है फिर दोबारा होता है। वो एससीए 1, 2, 3 नहीं है, बट उसका ट्रीटमेंट होता है, लाइक चैनलोपैथीज है, उधर दूसरे टाइप का जेनेटिक एबनॉर्मलिटी है, उसके लिए ट्रीटमेंट है। ओके। ऐसे रेजोलोमाइड करके ट्रीटमेंट होता है। सो ataxia is a very, very broad term. There are treatable ataxias. There are many, many type of ataxias are there which is treatable. अगर कुछ विटामिन का प्रॉब्लम है, कि मेटाबॉलिक प्रॉब्लम है, कि माइटोकॉन्ड्रियल प्रॉब्लम है, these are all treatable. और so in general, what the today's topic is, the commonest one of degenerative genetically mediated ataxias 1, 2, 3, 12, उसका टैबलेट ट्रीटमेंट कुछ नहीं है, फार्माकोलॉजिकल ट्रीटमेंट कुछ नहीं है फॉर tackling that balance problem. Otherwise, it is there many other things are there which we can symptomatically improve. Like if there is a fever, we give crocin, symptomatically improve कर सकते हैं, but underlying treatment नहीं कर सकते हैं इसका ataxia का.
सर इसी में फॉलो क्वेश्चन आया है, इज इट ट्रू अबाउट स्टेम सेल ट्रीटमेंट?
वही तो बोल रहा है जब अभी आई थिंक द फोर्थ टाइम आई एम रिपीटिंग दैट देयर इज नो रोल ऑफ स्टेम सेल ट्रीटमेंट इन क्लिनिकल फॉर ऑल द पेशेंट्स. इट इज ओनली अ ट्रायल बेसिस में. अभी उसका कुछ रोल नहीं है. हम लोग सो देयर इज नो रोल ऑफ स्टेम सेल ट्रीटमेंट. हमारा लास्ट 20 इयर्स में भी इधर भी बैंगलोर में हरदम करते हैं. बैंगलोर, दिल्ली, हमारा हॉस्पिटल के पीछे भी स्टेम सेल करते हैं. बट एब्सोल्युटली देयर इज नो रोल. नो वन शुड स्पेंड मनी on stem cell treatment. There is no role for SCA 1, 2, 3, 12.
एक एक क्वेश्चन और दे, दो क्वेश्चन और है. एक क्वेश्चन में है, दिस इज फॉर डॉक्टर गायत्री. थैंक यू फॉर प्रमोटिंग नॉलेज ऑफ. आर देयर एनी ऑनलाइन लर्निंग एंड प्रोग्राम्स?
Are there online learning programs?
I'll repeat the question. Thank you for promoting knowledge of genetics. Are there any online learning and training programs? I think ये question genetic counseling आंसर कर सकता हूँ, but Dr. Gayatri, over to you.
Yeah, there are several courses. काफी जो है that is also freely available. If you go to the board of genetic, if you are interested in genetic counseling, if you go to board of genetic counseling, there is the courses which is available in India. Or in general, if you want to know about genetics, so there is in Udemy, you will find in several portals you will find about genetics. There are courses like certificate courses, short courses.
I'll add to what Dr. Gayatri said.
And हम लोग अभी नया एक we are just about to launch what is known as the National Ataxia Network. ये इसी साल शुरू किया हम लोग. After the MDSI जो है मूवमेंट डिसऑर्डर सोसाइटी ऑफ इंडिया, उसका एक ब्रांच नेशनल अटैक्सिया नेटवर्क. अभी हम लोग 25 सितंबर उसको इनॉग्रेशन करेंगे, वो अटैक्सिया अवेयरनेस डे करके, जो ऑलरेडी वर्ल्ड में होता है 25 सितंबर. सो उसमें I will send you what we are planning. My main person who will be doing is Dr. Divyani Garg, but I am the main person who will be coordinating with her, and also Achal is there. So many people are there. It's a newly formed a subgroup where we want to network with patients as well as caregivers as well as doctors in India, and more this thing awareness what you are doing. So we may join hands with you only. One part of that will be that.